Hello and very good evening, friends. Are we all connected? And if I'm audible to you, please send me a thumbs up. So, is it visible? Am I audible? Okay, so yeah, welcome everyone. So this is a 5-week PSM punch that I had planned, and the target of these 5 weeks for me coming online is that we will be doing the complete course of community medicine or PSM in a matter of 5 weeks. So total, I will be taking 5 sessions which are online sessions, and the link for the schedule for all these online sessions is available on all the social media platforms. I will be primarily using Instagram, YouTube, and Telegram as 3 social media partners. Every day, as per the schedule, we will be posting on a Telegram group some of the questions, high yield facts. The same will also be posted on the Instagram and all the recent updates. On YouTube, I will be coming live on every Wednesday using the topic that we have covered in the previous week, and we are going to revise that topic. So I have divided into 5 equal sessions, and each session, each topic that we are going to discuss. I don't have the picture of the whole 5-week module, but I'll just probably write down in case many of you must already be having those topics or those sessions. So on week number one, we will be doing today communicable disease, non-communicable disease, and the related national health programs, which also include the NTEP, NLEP, and NACO program, NACP program. The second week will be from 29th March, that is from tomorrow, from 30th March till 5th of April. And on 5th of April, I will be again coming live with mother and child health, all the indicators, mother child health program, including plus the vaccines or the updates in immunization. Then on 12th of April, beta, I will be coming again live, that is on Wednesday, 12th of April. It will be all nutrition, environment, plus all other miscellaneous topics. All other miscellaneous topics will be discussed on the same day, on 12th of April. All other miscellaneous topics. Okay. So next, on 19th of April is a very important big day, 19th of April. That is particularly important for your INICET exams, because we are going to discuss everything regarding biostats, epidemiology, screening of disease. So this is like one day which has been dedicated to you can say medical research primarily. So medical research would include biostats, epidemiology, screening of disease. And then on 26th of April, that will be all the best type of small session we'll be conducting regarding the image based questions, regarding all the pictures, all the logos that we have, and any other things which you want to study from me, or which you have any doubts. And this is the topic. This is a PSM punch that I am doing for the students, dear students, who are aspiring for the INICET 2023 exam. So beta, I hope that you are benefited from this whole module, and I sincerely wish that you all must have completed all your topics which you were supposed to complete today. So from I already had given you a daily schedule, and that was starting from 25th of March, 26th March, 27th, 28th, 29th. I had given you when to do what all topics, and I hope that you must have done, because at the end of the day, it's not me who's going to give the exam, it's you who's going to give the exam. And if you are honest to yourself, if you are prepared very nicely, you are going to do very nice. Okay, so I have taken all the topics, previous year topics which have been asked in all the AIMS exam. I've taken up till 7 to 8 year topics. So it's not that I'm taking only 3 year recent topics, and every day, every like session, every week, Wednesday, I will be online, and we will be discussing around 30 to 50 MCQs on that particular topic. So total 5 sessions. So you are being exposed to 250 to 300 MCQs in community medicine. Let's take on the first MCQ, and this MCQ is for all the students who are aspiring for the NEET exam. And let's see how much you can do. Today, I think the font is slightly less, so just zoom into your screens and try to solve this MCQ. The first MCQ, all of the following are correct regarding Japanese encephalitis. So what do you think? All of the following are correct. Let me just try to zoom in for you. Okay. I hope this one is better. All of the following are correct for Japanese encephalitis, except humans are reservoirs. The main vector is Culex tritaniorhynchus. Main vector is Culex tritaniorhynchus. Or birds are the maintenance host. Or we have birds are the main, or option D, it has a seasonal transmission. So what do you think is the best answer over here? What do you think is the best answer over here? So what do you want to say? All of the following are correct for Japanese encephalitis, except. So I'll be waiting for around 5 to 10 minutes because there's of course a lag between the sessions, between the systems, and you should be all interactive in your answering, and you should be able to answer all these very easy MCQs. What do you think is the best answer over here? So humans are reservoir. That is absolutely the wrong answer. This is false. Main vector is Culex tritaniorhynchus. This is correct answer. This is correct. Birds are the maintenance host. This is also correct. It has seasonal transmission. Yes, this is correct. It has more during the rainy season or during the months of when we have monsoons in India. That is from starting from August till September or till October. These are the peak seasons for Japanese encephalitis. I would like you to remember this life cycle. It has been asked so many times in your exam that what is the life cycle for Japanese encephalitis. Please note that there is a bird and there is a mosquito cycle, then there is a pig mosquito pig cycle, and then mosquito sometimes bites the humans and the humans do not give it back. Humans are the dead end host. Humans, as always, will always keep on receiving things. I want this, mere ko ye bhi chahiye, but they will not give back. Please remember, humans are the dead end host. Please remember that humans are the dead end host. So Ashutosh कह रहे हैं कि is this session will remain on the YouTube? Absolutely correct. Yes, this session will remain on the YouTube. You don't need to worry, at least till INICET exams. This session will be free of cost available on YouTube. Humans are देख लेंगे. Humans are not reservoir. They are accidental host. Absolutely correct. They are not the reservoirs. देख लेंगे कह रहे हैं कि sir, seeing this today, can we start now if we missed the previous 6 days? Absolutely. जब शुरू करो, जब आँख खुले तभी सवेरा. Whenever you get up, that time it's the morning. So please remember that you have to clear the exam. कुछ भी करके, साम दाम दंड भेद, कुछ भी करके, we just have to clear the exam. So whatever you have in hand, you use that. Anyways, let's move to the next MCQ. So what is the best answer over here? Humans are the reservoir. This is the only wrong answers. Yes, the PDF will be available, Shweta. Next MCQ, which of the following, again I'll have to zoom into this, which of the following statement about polio is not true? What do you think you want to answer? Which of the following statement about poliomyelitis is not true? So you have to find the wrong one, which is not true. VDPV is because of mutations. VAPP is because of immune reactions. FIPV is given during polio outbreaks, and type 2 poliovirus is most easily eradicatable. So what do you think is the best answer? Which of the following is not correct? What do you think is the best answer? Which is not correct? VDPV, beta. What is VDPV? Let me take each of the options one by one. What is VDPV? VDPV stands for vaccine derived polio virus. It's a vaccine derived polio virus. This vaccine derived poliovirus, there are two entities to this word. It is a vaccine derived and it is a new novel type of poliovirus. So it is a type of poliovirus. So this VDPVs are always because of mutations. How much mutations? More than 2% change in the poliovirus. If it happens, it may lead to VDPVs. VDPVs can be of many types. VAP. What is VAP, beta? VAP stands for vaccine associated paralytic polio. VAP stands for vaccine associated paralytic polio. There are two entities to this definition. It is a vaccine associated. It is not a vaccine derived. It is associated with the vaccine and it's not a new polio virus. It is a paralytic polio. So can we say that VAPs, they are actually the side effects of oral polio vaccines? This is also a correct statement. VAPs are also the side effects of oral polio vaccine. This is also a correct statement. So VDPV is because of mutation. This is true. VAP is because of immune reaction. This is also true. FIPV is given during polio outbreaks. No, this is wrong answer. This is false option. It is not given during outbreaks. It is not useful during outbreaks. Why is it not useful? Because FIPV, it causes both, it causes only the humoral immunity, whereas the OPV, it causes both humoral as well as the gut immunity, and therefore it is given in the outbreaks. FIPV is not useful in the outbreaks. So this is the false option. Type 2 is most easily eradicatable. It was also the first to go. First to go was the OPV, was the type 2 poliovirus. This is also a true statement. So which is the best statement you're going to mark? FIPV is given during polio outbreaks. That is the wrong option. So option C is the wrong answer. Absolutely correct. Many of you have started answering. Let us move to the next option. Next question. Which of the following? Again, I'll have to zoom into this. Which of the following is not a type of the VDPV? So again, a question from poliomyelitis. Which of the following is not a type of vaccine derived poliovirus? Is it a CVDPV, AVDPV, IVDPV, or MVDPV? So please remember that C, A, I, and M, some of this is types of VDPVs, others are not. Very easy to remember. Please note that VDPV, we can have various types of VDPVs as CVDPV, IVDPV, and AVDPV. CVDPV stands for a communicating VDPV. It is the most dangerous type. It is the most dangerous type. And this is where the person-to-person transmission can happen. It is a communicating type of VDPV. On the other hand, IVDPV, it is mostly associated with immunodeficiency diseases, and in people who are kind of immunosuppressed, we should not say immunodeficient. They might have some aberrant immune status. They might have some kind of lower immune status, and there is kind of primary immunodeficiency and a prolonged VDPV infection that may lead to immunodeficiency associated VDPVs. AVDPV is something which we don't understand. When we don't understand, we say ambiguous VDPV, where the people do not have any source that we don't understand whether it is due to immunodeficiency or was it circulating, yes or no. It is mostly from sewage material, but the source is not discretely defined. That is called as AVDPV. MVDPV, which was there in the option, is not a type of VDPV. So what is the best answer you're going to mark? MVDPV. So we have dived into the types of VDPV. VDPV, that is vaccine derived polio viruses. These can be CVDPV, IVDPV, and AVDPV. So just remember what is C, A, and I. Next is which of the following statement is correct? So again, I'll have to zoom it. Let's zoom it. Which of the following? I think it's more. So which of the following statement is correct? What do you want to answer? Which of the following statement is correct? Sapna helps to improve leprosy awareness. Leprosy awareness in community is given by the rate of new cases with grade 2 disability per million population. Leprosy prophylaxis is given to all social contacts who work for more than 20 hours a week, or single dose rifampicin is given to all family members aged more than 6 months. What do you think you're going to answer over here? So which of the following statement is incorrect? You have to find the wrong option. You have to find the wrong answer. Which of the following statement is incorrect? Sapna helps to improve leprosy awareness. What do you want to say about this option? Sapna helps to improve leprosy awareness. So some students are saying Abhinandan option D, Vishnu option B, Ansh is saying C. देख लेंगे शायद से C लग रहा है. So leprosy is one topic which has been asked in all the exams, FMG exam, it has been asked in the NEET entrance exam, it has been asked in the INICET entrance exam. So all the entrance exam have been asking questions on leprosy since last 3 years. So 3 exams, like some are conducted twice a year, right? FMG, INICET. So maybe you can say 5 exams every year in last 3 years, 15 questions aaye hain leprosy mein se. Can you beat that? Leprosy is a very high yield topic. You have to remember, you have to learn about leprosy before you go forward. Learn about microbiology of leprosy. Usse bhi zyada, make sure that you learn about dermatology of leprosy, type 1 leper reaction, type 2 leper reaction, and how to treat them. And सबसे important is preventive medicine about the NLEP program, National Leprosy Eradication Program. So Sapna helps to improve leprosy awareness. Absolutely correct. Sapna is a cartoon character. Sapna is a girl child. It's a cartoon character. It is a mascot. Sapna is a mascot which is used to improve leprosy awareness. Leprosy awareness, option number 2, leprosy awareness in the community is given by the rate of new cases with grade 2 disability per million population. So what do you say on this option? If you look at the indicators, there are some very important indicators, beta, which you have to remember. This is a 5-star MCQ slide for you. Make a screenshot of this and keep it safe with you. It will be helpful in your exam. You have to remember the 4 important essential indicators. The first important essential indicator is the prevalence rate. So you have is the prevalence rate. Second important indicator is the ANCDR, annual new case detection rate, which is given per lakh population. Third is the grade 2 disabilities per million population. It is grade 2 disabilities per 10 lakh population or per million population. And last is, there is also a 4th indicator, that is the cure rate. These are the 4 important essential indicators. ANCDR, I'll repeat again, which are the most important indicators, most important epidemiological indicators. You can take note of this. These are 4 indicators. ANCDR, please remember. Second is prevalence rate. Third is grade 2 disabilities among per million population. This is per million population. Prevalence rate is per 10,000 population. ANCDR is per lakh population. And then we have is the cure rate. Okay, then you have is the cure rate. These are the 4 important indicators, beta. Ye aapko exam ke liye, you have to study them and go. So these are very important, frequently asked indicators. Please remember, what is the current prevalence rate? I don't think they will ask you, but this still can be a question, that the current prevalence rate for leprosy, we are proud to say it is only 0.45. It is 0.45 per 10,000 population. What is the current ANCDR? What is ANCDR? It is the annual new case detection rate. It is roughly around 5.5 per lakh population. So remember, the prevalence rate is only 0.5 or 0.45 per 10,000 population, and the ANCDR new case detection rate is 5.5 per lakh population. These all have been put as flashcards. These are available as flashcards on my Instagram channel as well. So these are available as leprosy. Just search for leprosy flashcards. These are available on the Marolinks group. They are also available on my Facebook. They are also available on my Instagram. Basically, I'm using Instagram to post all the updates. So search for leprosy flashcards. They will be asked in exam. They can be asked in exam. They are very high yield and very frequently asked in your exam. Search for these leprosy flashcards. So coming back to the story, what is the current level of prevalence rate? This is the 2023 data that I'm sharing. The prevalence rate of leprosy is 0.45, ANCDR is 5.5. So coming back to this, leprosy awareness in the community is given by the rate of new grade 2 disability per million population. This is also true. This is also true because it is absolutely correct. Option B is correct. Option C, Leprosy prophylaxis is given to social contacts who work for more than 20 hours per week together with the leprosy case. So social contacts who work for more than 20 hours per week, who are in close contact with the leprosy case for at least 20 hours in a week, would you give leprosy prophylaxis? Or option D, single dose rifampicin is given to all family members aged more than 6 months. So some of you have got this correct. Let us read about what are the inclusion criteria. This is again a 5-star MCQ topic for you. Make sure that you take a screenshot of this topic and you remember this for your exam. So take a screenshot of this topic and you remember this for your exam. Inclusion criteria. Beta, the first inclusion criteria is to identify as a contact the person who has been close contact for with the leprosy case for more than 20 hours per week for more than 3 months. So these are the people who are called as social contacts. Then is age more than 2 years. So age more than 2 years is important. It is given to all family members whose age is more than 2 years. If the child is younger than 2 years, we can give a single dose rifampicin only at the age of 2 years. So single dose rifampicin is given only at the age of 2 years or more than 2 years. So consent of the contact is obtained, and then in case the contact says no, I don't want to take any single dose rifampicin, then they are excluded, otherwise they all are included. So leprosy prophylaxis given to social contacts, this is true. Who work for more than 20 hours, this is also true. So option A is correct, B is correct, C is correct. Option D is the wrong answer. It is not given to age more than 6 months. It is given to age more than 2 years. What is the best answer you're going to mark? You're going to mark option number D as the only one option which is incorrect. Whenever you're going for INICET exam, a small trick I think many faculties must have told you, you are also very wise enough to know this, that make sure that you read the question correctly. AIMS exam, INICET exam is known for all of the following are correct, all of the following except which one is incorrect, all are incorrect except, all are true except, all are false except. So make sure you read the question carefully. एक दफा question को पढ़ लो. मेरा तरीका, my तरीका is my method. Whenever I solve MCQs, my method is I look at the MCQ. I forgot about what is incorrect, correct, वो बाद में देखेंगे. I look at the option, I just mark them true or false, and then उसके बाद question में देख लेता हूँ what did the question want to say. You have to mark the true one or the false one, वो mark कर देंगे. ओके एनीवेज आपका अपना तरीका है, एंड प्लीज़ मेरा एक यही था, मेनी स्टूडेंट्स लूज मार्क्स बिकॉज दीज इफ यू जस्ट सिंपली पुट वन रॉन्ग आंसर, तो यार योर रैंक विल गो फ्रॉम MD मेडिसिन टू MD बायोकेमिस्ट्री, राइट. सो ड्रीम ब्रांच अलग होता है, एंड यू टेक अ ब्रांच, एंड many students are messaging me that I wanted to take some clinical branch, I'm not able to get, so should I take non-clinical branches, what will I do, what will happen to my life. So please make sure कि उससे पहले ही अपने आप को prepare कर लो. Okay, so AIMS exam is known for these kind of MCQs. Let's go to the next MCQ and let's have a look at the next MCQ. In case of accidental exposure, the post-exposure HIV prophylaxis should be started immediately within what time? So this question, the same question I had put in my quizzes also, and the same question came in your NEET exam also. And HIV is again very important topic. It has been asked so many times in your exam. So let's have a discussion about a few points about HIV. In case of accidental exposure, the post-exposure HIV prophylaxis should be started immediately within how much time? 2 hours, 4 hours, 24 hours or 72 hours. क्या बोलना चाहते हो? What is the best answer? What do you think is the best answer over here? So it should be started best within how much time? Immediately, best within. What do you think is the best answer? I'm waiting for your answers. It should be started best within 2 hours, 4 hours, 24 hours or 72 hours. So many students would be saying option number 72 hours, but just have a look at this, and many times I take this in my classes also. Absolutely Shweta, you are correct. बाकी सब students option D mark कर रहे हैं. Just look at this. Maximum is 72 hours. It should be best started within 2 hours. Just look at this. I'll probably split this slide into 2 parts, and I'll delete this and I'll show you this. I'll just show you this. Look at this. Okay, Look at this. So this is from my class notes. This has been shared again on the Instagram. It is already there on your Telegram. These are small high yield points which I gave you just before my session today. So please note that in the class notes I have already written that what is the post-exposure prophylaxis. Can you read this? What is the post-exposure prophylaxis? It is given as soon as possible, within 2 hours, not more than 72 hours. If you are delayed for more than 72 hours, then there is no point of giving. Like, we can give ART, but usually more than 72 hours it is very less effective. The drug of choice that we use is TLD. What is TLD? Tenofovir, lamivudine and dolutegravir. The drug of choice that we use for prophylaxis, that is TLD. T stands for tenofovir, L stands for lamivudine and D stands for dolutegravir. TLD is given as the post-exposure prophylaxis. It should be best started within 2 hours, maximum within 72 hours. Next is, sometimes they will also ask you what is the prophylaxis given. So please note that in HIV we do not give any other opportunistic infection prophylaxis. We do not give for any toxoplasmosis. We do not give any prophylaxis for CMV retinitis. If they happen, you treat them and then you give prophylaxis, but you do not give prophylaxis for any. Listen to these words very carefully and make sure that you have a pen and paper and kahin pe likh lo ye meri baat. If this HIV patient is coming to me in the clinic, I have to ensure that is HIV patient का मेरा जो CD4 count है, I have to ensure that the CD4 count should be reasonably good. Just by chance, how many of you are students who do not understand Hindi at all? So just write it on the chat box if you want this whole session to be purely in English, or Hindi is also fine. So if we have any student who's watching me right now who does not understand Hindi at all, it'll be a pleasure to talk in English. But in case everybody understands Hindi, so it'll be a slightly more pleasure to talk in Hindi as well. So please note that if this HIV patient is coming to me in the clinic, I have to ensure, as a public health professional, we have to ensure that the CD4 count is good. Because if the CD4 count is good, obviously there will not be any opportunistic infection. Common sense. There is only one infection jiske liye we are giving prophylaxis. This is called as primary prophylaxis. There are two types of prophylaxis. Listen very carefully. There is called as primary prophylaxis and then there is a secondary prophylaxis. Primary prophylaxis is बीमारी होने से पहले. बीमारी होने से पहले. So Abhinandan is there, Vikashni is there. English please. Okay. Marathi, shabas. Next time I'll learn Marathi and come, okay? I love this language. It's a very sweet language. I love Marathi language. So beta, whenever this HIV patient comes, we have to ensure that we have to prevent the opportunistic infection, preventing the OI. This will be preventing the opportunistic infection. This will be known as like a primary prophylaxis. But in case the disease happens, any opportunistic infection happens, you treat that opportunistic infection and uske infection ke baad, after the opportunistic infection is over, then you give any prevention to prevent the recurrence. That is called as secondary prophylaxis. Okay. So there are two types of prophylaxis. One is called as primary prophylaxis and other is called as secondary. We do not give primary prophylaxis for any opportunistic infection. The only thing that we give is for pneumocystis jirovecii pneumonia. Only infection that we take care is pneumocystis jirovecii. This is the only one for which we give a primary prophylaxis. Please note, primary prophylaxis in HIV is only given for PCP pneumonia or pneumocystis jirovecii pneumonia or the pneumocystis carinii pneumonia. What is the drug of choice? The drug of choice is double strength cotrimoxazole. The drug of choice is double strength cotrimoxazole. And when do we start this double strength cotrimoxazole? It is started if the CD4 count drops below 350. And when do we stop it? When it is more than 350 cells for more than 6 months. This question came in your 2022 INICET exam. So this is a previously asked topic. Please note that the primary prophylaxis is given only for pneumocystis jirovecii pneumonia. And when do you start? If the CD4 less than 350. So these were a couple of questions. And next is, you can read this guideline. I have taken it from the National Technical Guidelines on ART NACO 2018. This is a direct screenshot from there. And HIV, I'll probably duplicate the screen and delete this. so that you can see this more clearly. So this time the ratio for font is not very nice. Anyways, so what you can see over here, these are the National Technical Guidelines on ART, NACO 2018. HIV post-exposure prophylaxis should be started as early as possible, ideally within 2 hours in all individuals who had an exposure to HIV transmission. There is little benefit if more than 72 hours have passed. So this question was directly taken from these guidelines, and this is what you had to answer. What is the best answer over here? You had to answer option number A, that is 2 hours, as the correct answer. So many of you have already answered it very nice and correctly. So very good. Very good. Let's move to the next MCQ. Which of the following is not correct? Which of the following is not correct? Again, a question from HIV. ART Plus Centers. ART Plus Centers are located in medical colleges. Link ART Center is a sub-district or a CHC level. Link workers are voluntary community health workers. ART centers are available at PHC level. So what do you think is the not correct or the false option? So if you look at basically the organogram of the HIV program, at the top beta we have something called as Center of Excellence. We have the Center of Excellence. Below the Center of Excellence we have ART Plus Centers. Then we have the ART centers. Below the ART centers we have the Link ART centers. And Link ART centers, they basically employ, or they have some people, these are called as link workers. So primarily speaking, beta, these link workers, these people, the link workers, these link workers, they are voluntary community level workers. Now the Link ART centers, these are available at PHC or the CHC level. Many of the PHC or the CHC, they can work as Link ART centers. ART centers are not available at the PHC, CHC. ART centers are available at district hospitals. ART center is available at district hospital. ART plus centers can be available at some of the bigger district hospitals. They can also be, they are mostly available in the medical colleges. And then you have some of the apex centers, Center of Excellence for HIV Research and Control in India. These are governed by the NACO program or the National AIDS Control Program. And this is what is the hierarchy or the organization structure of the NACP National AIDS Control Program. So at the top you have the Center of Excellence, ART Plus Centers. What is the use of ART Plus Centers? What do they do? ART Plus Centers, they are going to give the second line or the third line ART drugs. They also have the first line ART drugs, but they are more like, many people will be there who do not tolerate dolutegravir, or they do not tolerate lamivudine, and they have adverse reactions. So in those cases, you're going to help these patients by giving them some second line or the third line drugs. So second line and third line drugs, they are available at the ART Plus centers. All the first line ART, FLART, first line ART, FLART, first line ART, they are available at the ART centers. Where are the ART centers? At the district level. And then you have is the Link ART centers, that is the PHC, CHC, and below them you have the link workers. Coming back to this MCQ, which of the following is not correct? ART plus centers is located in medical colleges. This is true. Link ART center is a sub-district or a CHC. Link ART center. This is previous asked option. This is also true. Link workers are voluntary community health workers. This is also true. ART centers are available at PHC. No. ART centers are usually available at district level. They are usually available at district level. So option number D is the only one which you are going to mark, because it is false option. How much is the prevalence of HIV in India? Prevalence of HIV in India is roughly around 0.2% prevalence of HIV in India, because it is the proxy indicator in the ANC females. So option number D is correct answer, absolutely correct. Let us go to the next MCQ. This MCQ is again from TB and HIV. So which of the following is not correct? As a regime for TB preventive therapy, 6 months isoniazid, 3 months isoniazid plus rifampicin, 3 months of rifampicin and pyridoxine should be continued as long as INH or isoniazid is given. So this is a fairly easy MCQ. What do you think is the wrong answer? You have to mark the wrong option. Make sure that you mark it correctly. So which of the following is not correct option as a regime for tuberculosis preventive therapy? So what do you think you're going to mark over here? So I will give you the same plan for TB centers. Which of the following is not correct as a regime for TB preventive therapy? So which of the following is not correct? What do you think? 6 months isoniazid, 3 months of isoniazid rifampicin, sorry, and then you have 3 months of rifampicin. Pyridoxine should be continued as long as isoniazid is given. Many of you are answering option number C, which is fortunately and happily is the correct answer. If you look at the screenshot, this is directly from the guidelines by the NACO program, National AIDS Control Organization. It is for TB preventive therapy in case of HIV. Of course, it is the same one which we give in NTEP, National TB Elimination Program, the prophylaxis of TB. So there are two types of prophylactic regimes that we have right now. We have a 6 months of H, that is 6 months of isoniazid, or we can give a 3 months of H and P. What is H and P? H and P stands for isoniazid and rifampicin. 6 months of H, it stands for isoniazid. So these are the small points which you need to remember for your exam, that what is the type of preventive TB preventive options regimes that we can give to patients. So we can have these 6 months of H or 3 months of H and P. So coming back to this MCQ, 6 months isoniazid, this is correct. 3 months isoniazid plus rifampicin. Please note it is rifampicin, it is not rifampicin. This is also true. 3 months of rifampicin, this is the wrong answer. It is false. We do not give 3 months of rifampicin. It is 6 months of isoniazid. And pyridoxine should be continued as long as isoniazid is given. Why? Because isoniazid may be associated with vitamin B6 deficiency, and because of vitamin B6 deficiency, you have to give pyridoxine. So I think many of you must be answering this question correctly. Let us move to the next MCQ. Next MCQ is regarding tuberculosis, beta. It is regarding tuberculosis. It's a question which we freshly made, and you have to probably answer this based on your knowledge. So I'm waiting for your answers. Mr. Pappu presents with a sputum positive. This is a very important MCQ, I would say. Sputum positive pulmonary TB, and was started on ATT. ATT stands for anti-tubercular therapy. ATT stands for anti-tubercular therapy on 1st of August 2022. On 5th of October. So how many months? August complete, August, September, October. So somewhere around 2 and some months, August and September gone. He was found to be sputum negative and was started on a continuation phase. So immediately after 2 months, he was started on a continuation phase, and subsequently he comes on 5th or 3rd of January 2023 to the TB clinic for follow-up of the sputum and is found to be sputum positive. Bichara, he comes back as sputum positive. So he was taken as sputum positive, then he became sputum negative, and today again he is sputum positive. So he is classified as treatment failure, treatment default, recurrent TB or relapsed TB. What do you think is the best answer over here? So what do you think is the best answer over here? He was sputum positive, then became sputum negative, and again became a sputum positive case. Is it a recurrent TB, relapsed TB, default TB, or failure TB? So option, what do you think is the correct answer over here? Please note that these are very frequently asked definitions, and they have been asked multiple times in your exam. Many students are answering option number B, option number D, option number C as the correct answer. Okay, before I proceed, dekh lenge answers option A. Just look at this. Before I proceed, this is the same thing which has been shared with you on the Telegram. It is also there on the Instagram as a reel. It has been posted because many students asked for a quick review about the National TB Elimination Program. So in National TB Elimination Program, you have to remember some case definitions. Some case definitions have to be remembered. Please note that when do we call a case as a cured TB? Cured TB is any person who has completed TB treatment and has a document or sputum negative report. When do we say failure treatment? Failure treatment is any person, look at the screen, any person who's sputum positive. Failure person, when do we say treatment failure? Failure is any person who's sputum positive even at 5th month, or any time who becomes sputum positive after previous sputum negative report. So anytime if the patient was sputum negative declared and then the patient becomes a sputum positive again, you have to consider this as treatment failure. So this MCQ was pertaining to this topic only, that this patient was sputum positive when in August 2022, then he became sputum negative in October 2022, and then he again became sputum positive in January 2023. So what do you think this is? This is a clear-cut case of treatment failure. You have to revise your treatment schedule. You have to do drug sensitivity testing in this patient, and you have to reanalyze what category of this patient is. Why you all got confused? What is a relapse or recurrent TB? What is a relapse or a recurrent TB? Relapse or a recurrent TB? Beta, relapse or a recurrent TB is any time if the patient is sputum positive after completing treatment. After completing treatment, if the treatment is completed and then the patient becomes a sputum positive, that is called as a recurrent TB, or that is called as a relapse TB. Relapse TB or recurrent TB, it is the same thing, it is the same meaning, that is recurrent TB or relapse TB. That is recurrent TB or relapse TB. Okay, so please make sure that you're getting this correct. And please remember about this topic in your exam. It is highly asked in your exam. It is a 7-star topic. This may be asked multiple times in your exam. So please note this topic. So what is the best answer you're going to mark over here? It is a simple question, treatment failure. Next MCQ, let's talk again about a few topics from NACP or National AIDS Control Program. For a baby exposed to HIV, which of the following is not recommended? So which of the following is not recommended for a baby who is exposed to HIV? Exposed to HIV, which of the following is not recommended? Give nevirapine for 6 weeks. Give zidovudine if the mother was taking nevirapine based regime. Give nevirapine for 12 weeks if the mother is ART insufficient. Breast milk should be given for 6 months and then shifted to cow milk, because breast milk has a chance of transmission of HIV. So you do exclusive breastfeed and then put the child on cow milk. Option number D. So which of the following is not recommended by the NACO program? What do you want to answer over here? Which of the following is not recommended? So देख लेंगे. I'll talk about your doubt right now. Option D, Khushwant Bhatti says option number D is not recommended. So please note that whenever a child is born, if a child is exposed to HIV, that means a child is born to HIV positive mother, right? So if the child is exposed to HIV beta, immediately we are going to give nevirapine. This nevirapine should be given for 6 weeks. There are some exclusion or there are some MCQs over here. In case ICO का मतलब होता है in case of the mother is, in case the mother is taking nevirapine based regime, nevirapine based ART. If the mother was already on a nevirapine based ART, then there is something called as, mark the words, there is something called as archived resistance. Archived resistance. There is an archived resistance for nevirapine. Okay. So if the mother was taking a nevirapine based regime, now if the child is born to the mother who was taking a nevirapine based regime, it will be not useful for us to give a nevirapine to the child to prevent HIV, because the mother was already taking nevirapine based regime and there is chance of archived resistance to the child. So in case of mother was taking, you give zidovudine. You give zidovudine to the child. In case the mother is not taking ART or she was ART insufficient, In those cases, we advise the nevirapine should be prolonged for 12 weeks rather than to give it only for 6 weeks, double the time. There is also a third MCQ that in case of the child is very low birth weight, or the child has some problem with the immune system, or there is a high risk child, very high risk baby. In high risk children, or the mother was not taking ART, in these cases you can give a double regime, nevirapine plus zidovudine together. That has to be given for 6 weeks. So these are some of the exclusion criteria, or these are some of the important off the track criteria. Generally speaking, everybody should know that a child who is born to a mother who is HIV, you're going to give a nevirapine based regime. ये तो पक्की बात है, you're going to give a nevirapine based regime. So now nevirapine based regime is given to the child, and then you do EID. What is EID? Early infant diagnosis. You do early infant diagnosis, and this infant diagnosis is done at 6 weeks, and then we check whether the baby is positive or negative. All the time, please note that there may be question regarding the breastfeeding guidelines. When a baby is born to a mother, the breastfeeding should be continued. Baby is born to HIV positive mother, the breastfeeding should be continued. For at least 2 years if the baby is HIV positive, and it should be continued for at least 1 year if the baby is HIV negative. That means more the HIV, that means HIV baby positive हो गया, तो फिर तो positive हो गया ना. Now you should be giving, you should be advising the mother to give breastfeed to the child for at least 2 years, because the breast milk is considered as a safe diet, wholesome diet. It is easily available, acceptable to the child and everything. So please remember that breastfeeding, of course, breast milk may have a higher chance or higher probability of transmitting HIV viruses, but breast milk has more benefits rather than the risk. So breast milk should be continued for 2 months or 2 years in case of HIV positive, for 1 year in case of HIV negative, and never the breast milk, we never advise the breast milk to be stopped and abruptly change the milk. Abrupt changing of the milk, abrupt stopping or changing of milk is never advised. Never advised about abrupt stopping or changing of the milk. So what is the best answer you're going to mark? We are going to mark option number D as the best answer for us in this MCQ, because it is the only one which is false answer. It is the only one which is false answer. Let's go to the next MCQ. The currently given regime for Bancroftian filariasis. Now this is frequently asked MCQ again regarding lymphatic filariasis, and last few exams they have asked multiple times question on lymphatic filariasis. So currently given regime for lymphatic filariasis, what is the best answer? For lymphatic filariasis, what is the drug of choice, beta? For lymphatic filariasis, the drug of choice is, for lymphatic filariasis, Bancroftian filariasis, the drug of choice is, we give DEC for 6 milligram per kg per day for 12 days. It is a direct dose which you have to remember for your exams. There's nothing left and right, but lymphatic filariasis is a high yield topic for your exam. It is the drug of choice is single dose DEC 6 milligram per kg for 12 days. Next MCQ. Next MCQ. So insecticide of choice for sandfly control is, insecticide of choice for sandfly control is DDT, BHC, synthetic pyrethroids or malathion fogging. This question I had taken to be taken up for discussion because many wrong answers are available. In your PARC textbook also they write that DDT and BHC should be used, but unfortunately in the National Vector-Borne program we have stopped using DDT and BHC long time ago. The best answer over here is synthetic pyrethroids. Synthetic pyrethroids are the drug of choice for insecticide control for sandfly. A few questions on sandfly. What is sandfly? Sandfly is Phlebotomus argentipus. Phlebotomus argentipus. Sandfly is the fly which does not fly. It only hops, and it is a nocturnal insect. It is a nocturnal insect with a very painful bite. With a very painful bite, and the best answer over here is synthetic pyrethroids, which are used with very frequently. We use deltamethrins or cyfluthrins as synthetic pyrethroids for Sandfly control in areas which are Kala Azar endemic. Sandfly is a vector for Kala Azar, right? So Sandfly is a vector for Kala Azar, and the drug of choice and synthetic pyrethroids, of course, DDT, BHC, they can also be used. But in Government of India, under the National Vector-Borne Disease Control Program, we are not using DDT, BHC. We are only using synthetic pyrethroids. Next MCQ. Let's talk about the next MCQ. What do you think about the next MCQ? Which of the following is not a correct match? Rickettsia prowazaki louse-borne. Rickettsia typhi is a flea-borne. Q fever is a mite-borne. Rickettsia connori is a tick-borne. So I have remembered this rickettsial disease in a very easy manner. Of course, rickettsial disease is again a very high yield topic. It's a high yield topic, high yield point. Rickettsial disease, and I would sincerely advise you to study it from microbiology also. Very important. A lot of questions come from microbiology. If you are already enrolled with the Marrow application, you should watch all the lectures by Dr. Shivika ma'am. She has talked about rickettsial disease in a beautiful integrated manner, talking about clinical features, preventive measures, and microbiological aspects as well. Anyways, from your community health point of view, which of the following is not a correct match? What disease by what is the vector? So I have remembered rickettsial disease in a very silly and a very bekar manner. I'll share my mnemonic with you. Rickettsia prowazaki. iPhone Pro, it is large. So because iPhone Pro is large, and because it is large, I remember louse-borne. Prowazaki is louse-borne. iPhone, rickettsial phone, P, epidemic typhus. So you can remember iPhone Pro is large, rickettsial prowazaki is a louse-borne. Rickettsia typhi is a flea-borne. Remember that typhoid flies. Typhoid spreads like anything. Because the typhoid, that's my silly mnemonics I'm telling you. You can make your own ones, but these are just mine one. So typhoid fleas, I remember typhoid flies, and because typhoid flies like epidemic, so I remember that Rickettsia typhi is endemic typhus, and it is a flea-borne. It is also called as a murine typhus. Q fever is the only one which does not have an active vector. Q fever is a very special disease. There is no vector. In case MCQ comes, is there a vector? Yes, ticks can be vector. Ticks can carry the Coxiella burnetii or the Q fever organism, that is Coxiella burnetii, but predominantly humans do not get a tick-borne. Q fever is not a tick-borne. Q fever generally it is airborne, or you can say droplet-borne. Rickettsial connori, I have remembered it as a tick-tock corner. Remember tick-tock corner, tick-tock corner. I told you these are my silly mnemonics. Tick-tock corner, I have remembered it as connori is a tick-borne illness. So these are also given in the One Touch PSM book, which is available in all the leading bookstores in India, and it is available online also. It is by name of One Touch PSM. One Touch PSM is a book which has only 40 pages of community medicine. Total 40 pages is including all the chapters, 13 chapters in all the 23 chapters from Park textbook. All the important chapters, all the high yield points are available in this single book, One Touch PSM. Plus it has all the previous 4-year MCQ exams from NEET exam, FMG, INICET exam. So this is one of the table from this One Touch PSM book. You can remember this as Rickettsia prowazaki. iPhone Pro is large, it is epic. Typhoid fleas like endemic. Go for like urination in the shrubs. That's just my silly mnemonics. So I have remembered Rickettsia tsutsugamushi, or the Orantia tsutsugamushi in the shrubs is mite-borne. Right, tick-tock corner, you remember Rickettsia connori, and Coxiella burnetii. Q is a special alphabet, and because there is Q is a special alphabet, there is no vector, there is no fever, very less amount of fever is there, no rash, sorry, there is no rash, and there is no vector. Q is a special alphabet. So coming back to this MCQ, which of the following is not a correct match? Q fever is not a mite-borne. In case somebody asks you Q fever, so so in case somebody asks you about Q fever, it is tick-borne. But generally speaking, if you look at the life cycle, just look at this life cycle. So can you see this life cycle? I'll just put this over here. Can you see the life cycle? You see that this cats, sheep and goats, they are the main reservoirs of the Coxiella burnetii, and the primary mode is aerosol transmission. So it just flies in the air during the process of childbirth, or during the process of baby birth, reproduction of these animals. The Coxiella burnetii may just fly in the air, and people who are veterinary doctors and people who are farmers or who are handling these animals, they may be exposed to Coxiella burnetii and they get a Q fever type of disease. Vector transmission is kind of it's left and right. It's not a very predominant mode of transmission. Of course, if somebody asks you which vector is there, it is the tick. So these are some important MCQs which you should remember. Kushwan says, sir, in Marrow notes you have said DDT first line, BHC second line. Absolutely correct. DDT and BHC, they were used for Sandfly, but National Vector-Borne Disease Control Program, the program uses synthetic pyrethroids and not DDT and BHC. It is given in Park textbook, which is not a correct statement. As per the program, you have to answer the best one. The best one is synthetic pyrethroids. If given everything in the single screen, I told you, if given everything in the single screen, you have to choose the best one. The best one is synthetic pyrethroids. There's no doubt in that. So please take note of this. Coming to the next MCQ, again a question I think from tuberculosis. So question from tuberculosis. Let's make it 23. Okay. Okay. A patient was admitted with fever and microscopy of the blood smear was positive for not from tuberculosis, sorry, this is from malaria. A patient was admitted with fever and microscopy of blood smear was positive for Plasmodium falciparum. Treatment recommended as per the revised drug policy 2013 is, what do you think is the best treatment for Plasmodium malaria? So patient is admitted with fever and microscopy positive, blood smear positive. So what do you think is the best answer? Blood smear positive for Plasmodium falciparum. What is the drug of choice for Plasmodium falciparum? Please note that for Plasmodium falciparum, we are going to give, for Plasmodium falciparum, we are going to give artesunate 4 milligram per kg. Then we give sulfadoxine and we give pyrimethamine. We give sulfadoxine, pyrimethamine. All these three drugs are given in Plasmodium falciparum infection. This is called as ACT. What is ACT? Artemisinin based combination therapy. If you look at the doses, if you just want to look at the doses, artesunate is given at the rate of 4 milligram per kg body weight. Sulfadoxine is 25 milligram per kg body weight on day 1. Pyrimethamine is 1.25 milligram per kg body weight on day 1. So why do we say that for 3 days or day 1 or primaquine on day 2? So what is all this which is happening? If you look at the ACT which is given in Plasmodium falciparum beta, we give on day 1, day 2 and day 3. 3 days of drugs regime is given. On day 1 we give artesunate plus sulfadoxine plus pyrimethamine. So these 3 drugs are given on day 1. On day 2 we only give artesunate plus we give primaquine as a single dose on day 2, and day 3 is only artesunate. This whole thing is what we call as artesunate combination therapy with artemisinin based combination therapy with sulfadoxine and pyrimethamine, ACT-SP. Plus we also give the primaquine as single dose on day 2. In your exam, very rarely they will ask you any dosages, but at least remember the dosages for adults. This can be asked in your exam. The dosages for adults for artesunate, AS stands for artesunate. Then you have S and P, that is sulfadoxine and pyrimethamine. Then artesunate, primaquine and artesunate on day 3. So these are the drug dosages which can be asked in your exam. Only the adult dose you should remember. In case you have already remembered these dosages, I would suggest that at least remember the pink or the infant dose also. These are all in different colors. So 0 to 1 year is pink color. Then you have a yellow color, green color, red color and white color. White is for adults and pink is for infants age less than 1 year. So it's very easy to remember. If you watch my Marrow video lectures, there is a sequence. I have told you how to remember these drug regime, how to remember these dosages. But because this is just a YouTube live session and I want to save your time also, please remember the adult dose and remember the infant dose. Adult dose is slightly more important. What is the adult dose for artesunate? Artesunate we give as 200 milligram, plus we give 750 milligram of sulfadoxine, and we give 37.5 milligram of pyrimethamine. So artesunate, sulfadoxine and pyrimethamine. Artesunate is 200 milligram, 750 milligrams of sulfadoxine and 37.5 milligrams of pyrimethamine, plus we give primaquine on day 2, that is given at the rate of 0.75 milligrams per kg body weight. So remember these dosages which can be asked in your exam for artesunate artemisinin based combination therapy, ACT SP. It is given in all states except the northeastern states. What do we give in northeastern states, beta? It is ACT-AL. Remember, it is ACT-AL. Day 1 of symptoms nahi, day 1 when we start the treatment. So I think everybody got this question correct. What is the best answer over here? It is it is 200 milligrams of artesunate, sulfadoxine pyrimethamine daily for 3 days. This is wrong answer. Sorry, it is not given daily for 3 days. It is not given daily for 3 days. 50 milligram artesunate, this is also wrong answer. 4 milligram daily artesunate, sulfadoxine as single dose and primaquine as single dose. This is the best answer. Option number C is the most correct answer over here. So option B is not correct. Option D, 4 milligram artesunate if the patient were pregnant. No, in pregnancy, please remember malaria in pregnancy. This can also be asked, malaria in pregnancy. In pregnancy, we are going to give, please remember, first point is that no primaquine. Primaquine is contraindicated. Primaquine is contraindicated in pregnancy. So in case the patient was having a Plasmodium vivax, then you give only chloroquine. In case it is Plasmodium falciparum, now the issue comes. In case it was a Plasmodium falciparum, in these cases, what are we going to give? In first trimester, beta, it is quinine salts, which is given as oral drugs. And then in the second or the third trimester, we give the area based ACT, either ACT SP or we will give the ACT AL. ACT SP in all states except the northeastern states, ACT AL in all the northeastern states. AL stands for artemether and lumefantrine. So please remember, only this is given except the primaquine. Only this is given and no primaquine is given. So this is what is the treatment for malaria in pregnancy. So please remember that what is the best answer you would like to mark over here? It is 4 milligram artesunate plus sulfadoxine and pyrimethamine. Coming to the next MCQ, very important, frequently asked about typhoid. Coming to the gastrointestinal infections about typhoid. So what is the best answer? Which of the following is not correct? Typhoid conjugate vaccine is a single dose IM vaccine. Typhi 21A oral Typhi is a 3 to 4 doses oral vaccine. VI polysaccharide can be given to newborn with immunodeficiency. VI polysaccharide vaccine is a single dose intramuscular vaccine. So which of the following is not correct? You have to mark the wrong one, which is the not correct option. Typhoid conjugate vaccine is single dose vaccine. Typhi oral 21A is 3 to 4 doses oral vaccine. What do you think is the best answer over here? So what do you think is the is the best to mark over here? Which of the following is not correct? Typhoid conjugate vaccine is single dose IM vaccine. Typhi oral Typhi is 3 to 4 doses oral vaccine. VI polysaccharide can be given to newborn with immunodeficiency and VI polysaccharide is single dose. What do you think? This is a question from recent advances, beta. It is a question from recent advances in typhoid. Some of the MCQs which have been asked, this topic has also been shared in Telegram. It was there in Instagram channel also. Like what are the new vaccines that we have for typhoid? So which of the following is not correct? This was the flashcard which I had shared with you on the Instagram. It's there on Telegram. There are 3 types of vaccines which are now available for typhoid beta. We have the typhoid conjugate vaccine. This is the newly developed vaccine. These are the new vaccines. This is the new vaccine, the TCV vaccine, that is the typhoid conjugate vaccine. The earlier vaccine was a Typhi 21A, which is oral vaccine. This is oral vaccine and it is a live vaccine. It is oral vaccine and a live vaccine, and then we always had a VI polysaccharide vaccine. This is flashcard number 59 based on typhoid vaccines, which had been shared with you on various channels, and this new vaccine was incorporated in year 2022. Now talking about the typhoid oral vaccine, that is a Typhi 21A. This vaccine is 3 to 4 doses of vaccine are required, and it protects for a considerably very long time, that is 7 years. But the point is that the oral Typhi cannot be given to age less than 5 years of age. It is only given to age more than 6 years. This has been asked multiple times in your exam. It's a frequently asked MCQ. Okay, age less than 5 years, oral Typhi is not given, and it protects for more than 5 years. Just remember it this way. It is very good vaccine. It is given in 5 doses, 3 to 4 doses. So I have remembered multiple doses, not given to age less than 5 years. It is effective for more than 5 years. ऐसा चलेगा. Now coming to polysaccharide. Polysaccharide is typhoid bacteria का, salmonella का. You just take out the outer covering, and out of the outer covering you give the polysaccharide component. Now for a person to develop just try to understand, if I give the polysaccharide component to any person, the person will need to make the immunoglobulins against that polysaccharide, है ना? Now the person should be having a reasonable type of immune status or immune level to actually, the person should be capable to make the immunoglobulins. That means the person should be immunocompetent to make the immunoglobulins against a polysaccharide, and therefore polysaccharide vaccine, any polysaccharide, meningococcal polysaccharide, COVID polysaccharide, typhoid polysaccharide, pneumococcal polysaccharide, any polysaccharide vaccine is given to age more than 2 years. ये रट लो इसको. Typhoid vaccine, any polysaccharide vaccine is only given to age more than 2 years. That is, below 2 years, children will not have the capacity to produce the antibodies against the polysaccharide. Okay, so age 2 years is the problem with a polysaccharide vaccine, which is not the case with the conjugate vaccine. Okay, so please note that the polysaccharide vaccine is given to age more than 2 years. It is given 1 to 2 years, 1 to 2 dose vaccines can be given, and it needs booster again 2 years. Remember, 2 vaccines, 2 doses, 2 years, and it is given after 2 years. It protects for 2 years. And I hope you can remember. The oral Typhi is given age more than 5 years, protect for 5 years, and it is given in up to 5 doses, 3 to 4 doses. The polysaccharide vaccine, age more than 2 years, it is protective for 2 years, it is given in 1 to 2 doses. You can remember it this way, 5 years and 2 years. Coming to the conjugate vaccine. Conjugate vaccine can be given anytime. It can be given to age less than 1 year. Protection for age 1 year or 2 years. So remember, 1 to 2 years is protection time for typhoid conjugate vaccine, and it can be given to age more than 6 months of age. This is a new vaccine and it is given in single dose, 1 dose. So this is what you had to remember for your exam regarding the typhoid conjugate vaccine, which can be asked. So if you have understood this, typhoid conjugate vaccine is a single dose IM vaccine. Yes, correct. Typhi oral Typhi. TY21A oral Typhi is a 3-4 dose vaccine and oral vaccine. Yes, बिल्कुल ठीक है. This is also correct. VI polysaccharide can be given to a newborn. Newborn को कहाँ से दोगे, है ना? Newborn is 28 days. With the immunodeficiency, absolutely not. This is wrong. This is wrong. This is wrong option. Option C is not correct. VI polysaccharide is a single dose IM vaccine. Absolutely correct. This is the correct answer. So VI polysaccharide is given as single dose. Yes, it can be given as single dose, and the booster is given in the second time. And B and C is correct answer. So which is the only one which is wrong answer? Option number C you are going to mark as the best possible answer in this MCQ. I hope you have got this question correct. Let us now move to the next MCQ and have a look at what this NPSP is talking about. NPSP stands for the National Polio Surveillance Program. It's a polio surveillance, that is, we are watching the polio. So which of the following is not true? In a national polio surveillance project, which of the following is not true? You have to mark the wrong one. Start investigation of AFP within 48 hours. 2 stool sample to be collected within 14 days with a gap of at least 24 hours between the 2 samples. AFP reporting rate of more than 1 case per lakh population per year. So option C. Stool should reach laboratory in blue color cold chain boxes labeled as stool sample within 72 hours. What do you think is the not correct answer? So what do you think is the not correct answer? Which of the following do you think is incorrect? So I think we are just left with a few more questions, around 5-7 more questions. Let's just very quickly wrap it up. I was supposed to do it for 1 hour. Let's just do it in 1.5 hours and finish off this whole topic. फटाफट से बोलो बेटा, which of the following is not correct? Start investigation of AFP within 48 hours. Yes, this is correct. Absolutely correct. The investigation has to be started within 48 hours. 2 stool samples within 14 days with a gap of 24 hours. This is also correct. This is also true. Yes, 2 samples should be collected within 14 days, but the gap should be at least 24 hours. What is the quality indicators? What are the indicators? Indicators in the program. The indicators in the program, first is the AFP reporting rate. AFP reporting rate. The AFP reporting rate should be more than 1 AFP should be reported per lakh population per year. It has to be reported to the government of India. At least 1 AFP. Why do we say 1 AFP? Because AFP can also be because of poliomyelitis. It can also, AFP stands for acute flaccid paralysis. It can also be because of Guillain-Barré syndrome. It can also be because of transverse myelitis. It can also be because of traumatic neuritis. It can also be because of so many other enterovirus infections. So at least 1 AFP case should be reported per lakh population per year. Another indicator is the stool adequacy rate. Stool adequacy rate. How much should be the stool adequacy rate? Please note that the stool adequacy rate should be more than 80% of the stool sample they should be adequate. That means they should reach the laboratory, within 72 hours, and they should be good quantity. How much should be the good quantity in them? They should be more than 8 grams or a thumb size. So how should they reach the laboratories? They should reach within 72 hours with a reverse cold chain. They should reach with a reverse cold chain. So in a reverse cold chain, beta, they should reach laboratory in a red color, not a blue color. It should be a red color. Normally, vaccine carriers, you must have seen, the vaccine carriers are blue color. The stool samples are usually red colored cold chain boxes, and they are labeled as stool samples, and they should reach the laboratory within 72 hours. So option D is the wrong one. Option C is correct, B is correct, and A is correct. All are correct except option number D. I hope you have got this question correct. Next MCQ, very easy MCQ. This just because of the number of times it has been asked in your AIMS exam. I just included this in the session discussion today. Which of the following is true for hookworm disease? Everybody on this earth should be knowing the answer to this. Which of the following is true for hookworm disease? What do you want to answer? Which of the following is true for hookworm disease? Eggs are infective form. They preferred a hard and a clay soil. Extrinsic incubation period is 2 to 3 weeks, and they lay 10 to 20,000 eggs per day. Which of the following is a correct answer? So how would you remember this? Or what is the way to remember differences between Escherichiasis and hookworm? It has been asked so many times in your exam, and every time you remember, every time you forget. So which of the following is true? Batana hai beta. A. Somita Manna says A. Dekh lenge says D. Which of the following is true? True batana hai. So if you just look at, these are my rough notes which I had been taking during the classes. So these are just some of the notes I'm sharing with you. These are the screenshots of the notes. So important salient features that will help you differentiate between Escherichiasis and hookworm. How I have remembered, I will tell you. See, hookworms and Escherichiasis. Escherichiasis, remember as A. A stands for anda. I have remembered Escherichiasis ko somehow I have related to eggs. So which is the infective form in Escherichiasis? Escherichiasis is anda. Anda is egg. So I have remembered egg is Escherichiasis. If Escherichiasis has to transmit egg, has to transmit, or there has to be a mode of transmission to other people, the egg should be there in the soil. So eggs are the infective form, and eggs, they are not any larva, they are not any living worms. So the eggs can lay in a hard clay soil. So eggs can be there in a hard clay soil. And Escherichiasis, these are worms. Everybody knows that Escherichiasis, these are long worms, long round worms, है ना? Everybody knows these are long round worms. So they, because they are long round worms, 15 to 30 centimeters, they can extend up till 1 foot long. 1 foot long scale, they can be 15 to 30 centimeters. They are long round worms. They are hard clay, and A stands for anda. Anda is eggs are infective form. Done. Now come to the, if you remember Escherichiasis, hookworm is exactly opposite. Just remember hookworm. Bacha kya, wo eggs is infected. So hookworm, who is infective? It is the larva. Now if the larva has to transmit to other people, larva has to be there in the soil. Now what is the type of soil? If the soil was hard clay, how will the larva transmit to the other person? The soil should be soft and porous, है ना? Larva transmit hona है ना, egg नहीं होना. So larva is a soft and porous soil. And hookworms, Escherichiasis is a long round worm. Hookworm is a very small. It is few millimeters, not even few centimeters. It is very small worms, and they lay many eggs per day. That is 10 to 30,000 eggs per day. They lay up till 10 to 30,000 eggs per day. Escherichiasis is a very round, big worm, and they lay lakhs of eggs per day. So 2.5 to 3 lakh eggs per day are being laid by Escherichiasis. Hookworm is small number of eggs. These are smaller eggs. Remember, smaller worms, smaller eggs, and they are transmitted by larva. So if you just remember, that's just a way, that's just a story for us to remember. If you remember, hookworm kya hai? Hookworm is a very small worm compared to the Escherichiasis. Escherichiasis, A for anda. Yaad rakhoge, A for anda. Larva sounds like lava, which is soft semi-solid soil. Absolutely correct. ये भी तरीका है उसका याद करने का. But A stands for anda. So if anda you remember, the egg you remember, you can remember everything. So eggs are infective form. This is for Escherichiasis beta, not for hookworm. Prefer a hard clay soil. Of course, Escherichiasis will prefer a hard clay soil. Extrinsic incubation period. There's also one point. That extrinsic incubation period is like how much time it takes for eggs to mature and infect others. Extrinsic incubation period for Escherichiasis is 2 to 3 weeks. It takes up till 1 month. Whereas hookworms, they are transmittable. They are ready to transmit only in 2 weeks. So remember, 1 month for Escherichiasis. So this is also for Escherichiasis. Lays 20 to 10,000 eggs. This is true for hookworm disease. So which is the best answer over here? You're going to mark option number D. बिल्कुल ठीक है. अब आपने देख लेंगे. Absolutely correct. Option number D is the correct answer. If you understand this, this is a 7-star MCQ topic frequently asked in your exam about hookworm. What do we do to prevent hookworm as a public health problem? We check for the Chandler's index. Chandler's index is the number of hookworm egg. Chandler's index is the number of hookworm egg per gram of stools. Less than 200, no problem. More than 300 is a major public health problem. Chandler's index, because it is very high in India, therefore we have something called as National Deworming Days. What do we call? National Deworming Days. When do we have the National Deworming Days? The National Deworming Days are observed on 10th of February and 10th of August every year. So 10th of February and 10th of August every year, we have these National Deworming Days. On these days, we give 1 tablet of albendazole. What is the drug of choice? We give albendazole. 400 milligrams of albendazole is given. 400 milligrams of albendazole is given to everybody whose age is more than 2 years. This is what is National Deworming Days. You should also note that deworming is also done in pregnant females in the second trimester. In pregnant females in second trimester, we do the deworming in second trimester. So which is the best answer? Option number D. Let's move to the next MCQ. This MCQ is kind of important because there were, I don't know if you know about it, there were a lot of cholera epidemics in the world. Many areas in South America, they had cholera epidemics. Many areas in Africa, they experienced cholera epidemics. Country India is safe for now, but cholera is internationally looking disease. Like it may have a pandemic alert anytime because it was in epidemic alerts in many areas in South America, in Africa. So we can expect a question on cholera. So which of the following statement is not correct? Just remember which is not correct. So cholera outbreak may have epidemic tail. Disinfectant with Riedel-Walker coefficient of more than 10 to be used. Mass chemoprophylaxis with doxycycline can be done. And ORT is the mainstay for management, which is not correct. What do you think is the wrong one? What do you think is the wrong one? So everybody should be knowing that cholera outbreak has epidemic tail. Once there is cholera outbreak, if there is any cholera outbreak, it is very difficult. It is very difficult to control this outbreak. So I'm just showing you a screenshot from my class notes. So cholera outbreak, beta, whenever it happens, it may have epidemic tail because there is something called as force of infection. That is, so many people start transmitting cholera. People who are healthy, because cholera has healthy carriers also. So people who are looked to be healthy, they may even transmit cholera. So there is something called as force of infection, and it is very difficult to control a cholera. Please remember that mass chemoprophylaxis is never advised. However, chemoprophylaxis is advised. Chemoprophylaxis, mark the words, the mass chemoprophylaxis is never advised, but the chemoprophylaxis can be advised. The drug of choice is tetracycline or doxycycline can be given, but mass chemoprophylaxis is not done. It is not done. Why is it not done? Why is it not done? Because so many people are carriers. We don't know who is a carrier. So we cannot do chemoprophylaxis in carriers because they are transmitting people, right? So mass chemoprophylaxis is not done. But if somebody says prophylaxis, can it be given to people who are health workers? If you as a doctor go to a cholera epidemic area, you will take a cholera vaccine and you will also take a chemoprophylaxis for cholera because you're working in a cholera epidemic area. So what is the drug of choice? We give tetracycline or doxycycline, but mass general chemoprophylaxis for cholera is not done. Disinfectant with Riedel-Walker coefficient. Please remember that disinfectant with the coal tar disinfectants with Riedel-Walker coefficient of more than 10 is to be used. So a Riedel-Walker coefficient of more than 10 is correct answer. This is true. This is true. Mass chemoprophylaxis with doxycycline is not done. It is false. It is mass is not done. ORT is, of course, it is true option. So which is the best answer? Option number C is the best answer to mark for your exam. Next is, what is true regarding the mass drug prophylaxis? What is true regarding the mass drug prophylaxis, mass drug administration in lymphatic filariasis? Again, a question on lymphatic filariasis. What is true regarding mass drug administration? MDA is done with DEC and ivermectin in all areas in India. Transmission assessment survey, this is also called as TAS survey. So TAS survey is done in under 5-year children. MDA is done after a filariasis survey is done in all age groups. MDA is given after filariasis survey is done in all age groups, or last option is the MDA coverage should be more than 50% in the endemic areas. So what do you think is true for mass drug administration? Now the question is asking which of the following is true. It is not asking about which is false or which is incorrect. Which of the following is true? So MDA is done with DEC and ivermectin in all areas. What do you think? Please note that as per the recent guidelines, I'll just show you, this is the flashcards which are there in a lot of Instagram channels. This is actually a screenshot from my book, that is the conceptual review in PSM, CROPSM, conceptual review of PSM. The last edition was third edition, which was 2 years back. But anyways, this book is still valid. So lymphatic filariasis elimination by year 2020, that was the theme at that time. What we are doing in India is MDA. MDA stands for Mass Drug Administration. Please note that as per the Government of India and the World Health Organization, they have recommended that the countries should be using triple drug regime now. That is IDA. IDA stands for ivermectin, DEC and albendazole. 3 drugs to be used. So now we are not using DEC plus albendazole. We are now using DEC, albendazole and ivermectin also in most of the states in India wherever lymphatic filariasis is a major issue. So one is this thing update for you. It is a recent update that MDA we do not use 2 drugs, we use 3 drugs. What are the 3 drugs? That is I, D and A, ivermectin, DEC and albendazole. Now as 6 rounds of MDA is done, and every time the MDA coverage should be more than 65%. It should not be 50% that was there in the MCQ. It should be more than 65% treatment coverage should be there. Now MDA, after MDA we do it in children age 6 to 7 years, not less than 5 years. It is done after age of 6 years. In these age group, if you find the lymphatic filariasis prevalence to be more than 2%, it is a problem. Less than 1%, we say you are okay, it is lymphatic filariasis eliminated. So once the MDA is done usually after conducting the survey. Can you read this? I'll duplicate this slide and delete this portion. And just look at this point over here. Just look at this point over here. Yeah. So mass drug administration, can you read this now? Mass drug administration is done after conducting the survey. The survey is usually done in 4 sentinel sites, 4 random sites in every district, taking 4,000 slides. You don't need to go into detail, but the MDA, mass drug administration, is done after conducting the survey. So the recommended strategy to interrupt lymphatic filariasis is single dose administration of MDA. What is the MDA we use? We use IDA, that is ivermectin, DEC and albendazole in all districts and endemic and areas who are endemic for lymphatic filariasis, not given in the whole country. It is not given in the whole country. So that was the question also which was asked in NEET exam, and a lot of students got confused that what is happening. Is it lymphatic filariasis or elephantiasis? Do we do peripheral blood film examination or microfilarial survey, or do we do ultrasound of the testis, or do we do check for antigens, or do we do RT-PCR, or do we do whatever? Like, please note, DEC provocation test is one of the tests, but it is not adopted by Government of India. In Government of India, we do TAS survey. TAS stands for Transmission Assessment Survey, and these are antigen antibodies assessment surveys. In these, if a person is found to be antigen antibody positive, one is you take the data for declaring an area as lymphatic filariasis eliminated or eradicated or whatever, major public health problem or not a public health problem. That is for data and recording purpose. But what will you do to this patient who is lymphatic filariasis like antigen antibody positive? To this patient, we send them for a microfilarial survey. So MDA is to be done after conducting the survey. After you do peripheral blood film examination, you find out, and then if in case the survey shows a major public health problem, you do MDA. MDA stands for mass drug administration. Mass drug administration has to be done for how many rounds? Can you see this? It has to be done for 5 to 6 rounds of MDA. Like for 5 to 6 years, we will keep on doing MDA. Every year we do mass drug administration. Then we call up WHO that, hey, I have done MDA for 5-6 years. Please come and do a transmission assessment survey. They will do a TAS survey. So how will they do the TAS survey? The TAS survey they will do using antigen antibody prevalence, and then they will check and they will tell us about the public health issues, right? So this question was twisted and asked in NEET exam. This question has been asked a lot of times in previous INICET exam. So make sure you are going okay with lymphatic filariasis, because lymphatic filariasis is one disease on which Government of India is also spending a lot of money, because we want lymphatic filariasis elimination in India. So you have to be sure that you know about lymphatic filariasis, because this is a competitive exam. The more you know, the better chances are for you to succeed, right? So MDA, let's discuss the options now. MDA is done with DEC, ivermectin in all areas. No, I don't think it's done in all areas. It is only in endemic areas, and it is not done with DEC and ivermectin. We have started using IDA, so option A is false. Option B, transmission assessment survey is done under 5 year. No, it is done for 6 to 7 year age group. It is not done in children age less than 5 years. It is done in children age less than 7 years but more than 5 years. Option B is true. Option B is false. MDA is done after a filariasis survey is done in all age groups. This is also correct. This is true. It is done after a filariasis survey is done. So this is true. The MDA coverage should be more than 50. Nahi hai. It is 65% in endemic zone. This is false. So which of the following you're going to mark in your exam? Option number C, because they asked which is true. So MDA is done after a filariasis survey is done in all the age groups. I hope you have understood this topic, right? Ivermectin is not given in all areas. I think absolutely correct, MA. So Dr. MA is absolutely correct. Ivermectin is not given in all the areas. It had been started in roughly around 60 to 70% of the lymphatic filariasis districts in India. They are giving triple drug regimes. Other are very soon to follow. It is not that it is not given. It will be given in any time to come, because government NVBDCP, they have adopted this triple drug regime. So अब थोड़ा तो time लगेगा ना for the things to percolate. Ivermectin वहाँ तक पहुँचने को, guideline and people training and so many things happening. So I would not say ivermectin is not given, but today it is not given. It will be given tomorrow, because government has adopted this policy of giving a triple drug regime. Let us go to the next MCQ. Let us go to the next MCQ. I think this is the last question from communicable disease. Next in line, we have a few questions, not very large number of questions. I think only 2 or 3 questions we'll discuss from non-communicable disease, and that will be all for the day. This question is a highly rated MCQ. One of the friends who is a veterinary doctor, this question is from rabies. One of our friends who is a veterinary doctor completed his 3 doses rabies pre-exposure prophylaxis around the previous INICET exam. So when we were giving the previous INICET exam, at that time, the veterinary doctor had completed his 3 doses. So when was the previous INICET exam? Somewhere in November 2022. So indirectly, the question wants to say that the person had taken the last dose, completed the 3 dose pre-exposure prophylaxis in November 2022. Next in line, unfortunately today, he calls you up and tells about an unprovoked deep tissue bite by the stray dog. The best advice you give on phone, as he calls you up before every INICET exam. So now you all again have an INICET exam pending. So now today, let's say it is 29th of March. So today in March, he comes back again and tells you that what to do. So 5 dose IM regime with rabies immunoglobulin, 3 dose IM regime with rabies immunoglobulin, only 2 dose ID or IM without rabies immunoglobulin, only RIG and wound management without anti-rabies vaccine. So what do you think you're going to do to this person who gives you a call around the every INICET exam? So last November he called you, and now again in March he's calling you. What do you want to say? This question is from rabies. You already know about rabies. Rabies you should be knowing in and out, because rabies is also one disease which is talk of the town, especially in states of Himachal Pradesh. It is especially in states of Delhi. It is especially in states of Tamil Nadu. They have high chances, high endemic areas for rabies in India. So what do you think is the best answer? I think everybody has got the question correct. They have got the options correct. They have got the answers correct. I'm so happy for you. Abhinandan, Sanyo and Princey, Shweta, Vishnu, Somita, Abhinandan. Absolutely correct. Option number C is the correct answer. Only 2-dose ID or IM without rabies immunoglobulin. Just a few points about rabies. You all remember that there is a re-exposure prophylaxis. Re-exposure prophylaxis is given not to previously dog bite cases, it is given to previously immunized person. Mark the words, it is not given to previous dog bite cases, it is given to previously immunized people. They will get a re-exposure prophylaxis. Difference है थोड़ा, आपको लगेगा कि ये क्यों बोल रहा है सर ऐसा कि it's not given to previous dog bite, previously immunized, क्यों emphasize कर रहा है, but that's how you are going to remember, and make sure you remember it correctly. It is given to previously immunized people who have completed their immunization more than 3 months ago. So this has been this controversy has been cleared out by the National Rabies Control Program guidelines also, that in all people who have taken previous immunization, it could be the post-exposure, it could be the pre-exposure, any type of exposure prophylaxis, if they had taken more than 3 months ago, they need a re-exposure prophylaxis. If they have taken within 3 months, then no problem. So it is given to people who are previously immunized more than 3 months ago, and no rabies immunoglobulin is given. What is the regime? What is the regime we are giving? We are giving on day 0 and day 3. We give intradermal or we give intramuscular vaccines or doses. Intramuscular is given as complete vial. What is the dose? It is a complete vial. What is the dose for intradermal? It is 0.1 ml. Dose is 0.1 ml intradermal. It is given in one site only, single site. Intradermal 0.1 ml, intramuscular is complete vial. You give it, there is no requirement for rabies immunoglobulin. This flashcard has been shared multiple times in your exams. This is a 7-star flashcard. Remember what is the post-exposure prophylaxis. Please remember what is the post-exposure, pre-exposure and re-exposure prophylaxis. It has been asked multiple times, so make sure you take a screenshot of this and remember this for your exam. You should also note about rabies immunoglobulin. Rabies immunoglobulin, what is the dose? Beta, rabies immunoglobulin is given as a human rabies immunoglobulin. Human rabies is given at the rate of 20 international units per kg body weight, and this is given as majority or the maximum should be given within infiltration. It should be infiltrated. It should be infiltrated within the wound, and whatever is left out, it should be remaining should be given in nearest intramuscular site. Remaining should be given in the nearest intramuscular site, and maximum should be infiltrated within the wound. That is for rabies immunoglobulin. Equine rabies immunoglobulin is not usually used. The dose is 40 international units per kg. It is not usually used. Human is much more safer. So based on this MCQ, I think everybody got this question correct. Only 2 dose for intradermal or 2 dose intramuscular, day 0 and day 3 should be given in all these cases. Now coming to your favorite topics of non-communicable disease. Beta, non-communicable disease is talk of the town. I can guarantee you lot of questions on non-communicable disease. Why? Because non-communicable disease is the leading cause of death. Cardiovascular disease is the leading cause of death. Whooping 33% of deaths, 35% of all the deaths which happen in India is because of cardiovascular disease. So it's a very high risk area for your entrance exam, because the government also wants everybody to be knowledgeable about the non-communicable diseases. So which disease has the highest proportional mortality? It is cardiovascular disease. So coming to the next MCQ, screening for diabetes is done in the peripheral centers using fasting blood glucose, random HbA1c or 1 hour glucose tolerance test, OGTT. 1 hour OGTT, HbA1c, random blood glucose, or the fasting blood glucose. I know this has been a previously asked NEET exam and INICET both exams they had asked this, that peripheral centers, even if they ask you PHC, even if they ask you CHC, always your answer has to be fasting blood glucose. If they ask you sub-centers, then it can be fasting blood glucose or random blood glucose. But if they ask you PHC or CHC, it's single best answer, fasting blood glucose. Just look at this screenshot from the guidelines. I'll just duplicate this screenshot and I'll zoom in it for you. Look at this. Can you see this guideline over here now? So this is the algorithm. So this is the algorithm for screening of diabetes in peripheral centers. This has been taken from the manual, from the technical guidelines for training of medical officers for non-communicable disease. So screening of all adults age more than 30 years of age, we do it using random capillary blood sugar values. So what is the criteria we use? Beta, can you see over here? We use fasting blood glucose, or we use a postprandial blood glucose. We can also use fasting blood glucose postprandial, or we can use a 2-hour post meal or 2-hour after glucose tolerance test. So what is common in all of these? What is common? It is fasting blood glucose. What is common? It is fasting blood glucose. But yes, postprandial blood glucose, that can also be used in a PHC level. In a subcenter, I told you it is fasting. In a subcenter, I told you it is fasting blood glucose or a random blood glucose. That's all. In PHC, or where the doctors are sitting, PHC or the CHC, the best answer is a fasting blood glucose. The second best answer is a postprandial blood glucose. And even if you refer to a healthcare facility, that is, even if the patient goes to a CHC level, then they will be assessed using fasting blood glucose, or they will be assessed using 2-hour post meal, that is postprandial blood glucose, or after giving a glucose tolerance test after 2 hours. Okay, so please make sure that you note these guidelines. What is the best answer over here? It is fasting blood glucose. What is the best answer? It is fasting blood glucose. And what is the target you want to achieve? You want to achieve a random blood sugar of less than 120 mg per deciliter. You want to achieve a random blood glucose of less than 120 mg per deciliter. So what is the best answer over here? It is fasting blood glucose. I know HbA1c, you have been taught in medicine, HbA1c is the most sensitive criteria, but it is not available in the peripheral centers. It is not available in the PHC, CHC. Of course, it is available in the district hospitals. HbA1c is a routinely used test in district hospitals, but in peripheral centers, what is the best answer? It is fasting blood glucose. Next is, which of the following is not a warning sign for cancer? Which of the following is not a warning sign for symptomatic cancer screening? So persistent fever, nagging cough, chronic indigestion, or change in what or moles. Which of the following is not a warning sign? So what do you want to answer over here? Which of the following is not a warning sign for symptomatic cancer screening? It's a very simple question. You must be knowing that for cancer we use a mnemonic, or we use a system called as caution. Caution, C stands for change in bowel or bladder habits. A stands for wound that is not healing. U stands for unusual bleeding. T stands for thickening or some lump in the breast. I stands for indigestion. And obvious change in what or mole, that is O. And N is nagging cough. Caution. Caution is a warning signal for cancer. And out of these, persistent fever is in fact not a feature for cancer. It is a feature for HIV, it is a feature for tuberculosis, for many other diseases, but usually not for cancer. Persistent fever is not a feature for cancer. For cancer we have these warning symptoms, that is option number B, C and D. It's a direct question and direct answer. So very frequently they will ask you, like, what are the most common cancers? For cancer, you have to remember which is the most common cancer. It is about the cancer incidence. What is the most common cancer in India? The most common cancer in India is a breast cancer, followed by lip oral cancer, followed by cervical cancer. So most common cancer in India is breast cancer, followed by lip oral cancer, followed by cervical cancer, cervix and uterine cancers. So this has been asked multiple times, and this is what you need to remember for your exams. Also, please note that the Cancer Registry Program 2020, they gave a report that, listen to it, cancer of the lung, mouth, stomach and esophagus were the most common. It does not say that lung is the most common. So, but this cancer registry program was done only in some of the sites, and this was done long time back in 2016-17. So the current data that we are using is the GloboCan data. It's a GloboCan data, and this is by the WHO, and this is more reliable. It's also there in your Park textbook. Anyways, just to cut the long story short for your exam, which is the most common cancer in India? It is breast cancer. It is breast cancer, followed by lip oral cancer, followed by cervical cancer. All three important cancers are there in India. It is not about the lung cancer. Coming to the next MCQ. This question is a direct question from OBS and Gynae. It is, you can say, integrated medicine type of question, or you can say it is more from a Gynae perspective. But of course, we have to train the medical officers who are sitting in the PHCs, or the MBBS graduates who are sitting in CHCs also. They should be trained how to diagnose cervical cancer. So this is the question from cervical cancer beta, training for you on how are you going to deal with cervical cancer. Any female who comes with undiagnosed vaginal bleeding, or specifically talking about vaginal bleeding which happens, or spotting which happens after sexual intercourse, in those females we do visual inspection with acetic acid. The acetic acid that we use is 3 to 5% acetic acid. Please note, pap smear is not the investigation of choice in peripheral centers. It is not the investigation of choice in India for diagnosing or finding out cervical cancer. In India, we use as visual inspection with acetic acid, VIA. So let's read the MCQ. A 35-year-old female is reportedly found to have faint line like acito-whitening at the junction of the columnar and the squamous epithelium on visual inspection with 3 to 5% acetic acid. So this female underwent a visual inspection with acetic acid. Probably she was having some bleeding after sexual intercourse, and the next step is, what do you want to do? Refer the female patient for cryotherapy. Refer the female for biopsy, pap smear or further investigation. Follow up after 1 year or follow up after 5 years. So what do you think you are going to mark over here? There's a question which is kind of, you can say, integrated with OBS and Gynae topic. What do you want to say in this MCQ? So I'm waiting for your answers. What do you think about this cervical cancer? How to diagnose cervical cancer in a peripheral system with the existing public health infrastructure that we have in India? So what do you want to say? If you look at the visual inspection, everybody would be liking to go with option number B because you want to discuss more about the pap smear. But this question can be asked in your exam beta, how to find out, how to understand the results from a visual inspection with acetic acid. So I do not want to show you any images because that is more from Gynae perspective. They will be showing you images, but at least remember that when to say visual inspection with acetic acid as positive or negative. It is taken as positive whenever we see acito-white lesions far away from the transformation zone in the cervix. Distinct opaque acito-white area. If it is distinct, it has to be distinct opaque acito-white area. Margin should be well defined and abnormality close to the squamo-columnar junction in the transformation, not far away from the os. When to say it as negative? Negative is if there are no acito-white lesion, or if there is faint line like acito-whitening at the junction of the columno-squamous junction, epithelium junction. So if there is faint line, or the Nabothian cyst becoming acito-white, transparent lesions, or faint patchy lesions without definite margins, all these are taken as negative. They might be showing some mild inflammation, but they are not positive for visual inspection. When to say positive? If there is distinct line which may be which is with defined margins, which may or may not be raised, and the lesions are far away from transformation zone. Okay. So, of course, in case of invasive cancers, obvious growth or ulcer may be seen, and the aceto-white areas may not be visible because of bleeding. But when to take it as negative, you should be knowing. So, what to do in case the visual inspection is positive or negative? In case it is positive, what to do? In case it is positive, there is aceto-white lesions at the squamocolumnar junction within the transformation zone, not far away from the os, or there is opaque aceto-white areas, or the margins are well defined. What are you going to do in case it was positive? In case the VI is positive, we have to refer the patient to a gynecologist. Simple as that. You have to refer it to district hospital or to a nearest FRU where the gynecologist facility is available. They will decide if the patient is available, is applicable or eligible for cryotherapy, yes or no. So if the patient is eligible for cryotherapy, they will do cryotherapy. If not eligible, they will do biopsy, and then they will grade the cancer as low grade, medium grade, high grade, or what to do with that cancer. Now, in case the patient is VIA negative, now, what to do in case the patient is VIA negative? The guideline says that the VIA, visual inspection with acetic acid, 3 to 5% should be repeated after 5 years. So 5 years repeating with VIA is what the Government of India guideline is for management of cervical cancers in India. So follow up after 5 years is the best possible answer. लगा जोर का झटका धीरे से. So या धीरे का झटका जोर से. So this is follow-up after 5 years is the best possible answer for cervical cancer if the patient is VIA negative. Okay, so don't get confused by pap smear. Of course, you can refer to the pap smear, but as per the guidelines of cancer screening program, the VIA, it is negative if it is a faint line-like aceto whitening at the junction of the squamocolumnar epithelium on the visual inspection. It is negative for VIA, and follow-up after 5 years has to be done. Next MCQ. Yeah, let's make it happen. देखा जोर का झटका धीरे से ही लगता होता है, ऐसे ही होता है. So these are what are aims like INICET like MCQs है ना. यही पूछ सकते हैं और क्या होता है. We have to prepare you guys. Like the public health people have to prepare you guys. Of course, I don't want you all to work in the rural areas, but the government wants to prepare you guys to, in case somebody works in rural areas, वहाँ पे क्या करना है. तो यही guidelines होती हैं. These are the guidelines which try to train the medical officers, and they get trained on these guidelines how to handle the cases. We are not saying that every patient will be saved by this, but we are not saying that no patient will ever benefit from this also. Maximum people will get benefit from this, right? Question number last, I think. No, one more question. This is the second last question. Steps approach include all of the following except. Let's just very quickly finish off the game. Steps approach include all of the following except. Steps approach include all of the following except physical measurements, blood samples, mental stress index, nutritional and demographic profile. So what do you think? Steps include all except. गलत वाला बताना है. Physical measurements, blood samples, mental stress index, and nutritional demographic profile. Steps approach is used to find out the non-communicable diseases. Steps approach. It is used to find out the non-communicable disease, specifically talking about the cardiovascular disease. Specifically talking about the cardiovascular disease. So there are 3 steps in the step approach. We have step 1, step 2, and step 3. The first step is a questionnaire based where we talk about the socio-demographic profile. We talk about the alcohol consumption, the psychological aspect, physical inactivity, nutritional aspect. In the second step, we do physical measurements in terms of height, weight, BMI, waist circumference. And in the third step, we take the blood samples. In all these 3 steps, please note that the mental stress index is not considered. Physical measurements, blood samples, and nutritional and demographic profile all are taken in the steps approach except the mental and the stress index. So please remember that this is what is a steps approach. This is a small flashcard for you. This is a 7-star flashcard. Take a screenshot of this. This will be asked in your exam. This flashcard talks about the recommended cutoff values. This is direct screenshot from my textbook Conceptual Review in PSM. third edition, and it is recommended cutoff values and what are the indicators. Very frequently they ask you like what is the waist circumference, waist to hip ratio, physical exercise, how much should be there, dietary cholesterol ka kya level hai, HDL, LDL cholesterol, and all these things, right? So very frequently asked in your exam. Next is again a question from cardiovascular diseases. Again a question from cardiovascular diseases. Which of the following is not a target under the Global Action Plan for controlling NCD as a public health problem? What do you think you want to answer? I told you that government is going very strong in about a non-communicable disease, because so many people die because of non-communicable disease, right? So which of the following is not a target under the Global Action Plan to control NCD as a public health problem? Which is not a target? What do you think is not a target? So 10% relative reduction in harmful use of alcohol, 10% relative reduction in prevalence of insufficient physical activity, 30% relative reduction in mean population intake of salt sodium, 30% reduction in the prevalence of raised blood pressure. What do you think is the best possible answer over here? So which of the following is not a target under the Global Action Plan to control NCD as a public health problem? What do you think you're going to answer? So option number D, relative reduction in 30%. Option C, relative reduction in mean population intake. Option B, relative reduction in prevalence of insufficient activity. Or option A. What do you think is the best answer? What do you think is the best answer? Yeah. So if you just look at this beta, this is again a screenshot. It has been asked so many times in your exam. This is a frequently asked question, frequently asked topic. I'll make it easy for you to remember. This is multiple times asked in your exam about the Global Action Plan, about the targets. So you want to decrease the risk factors for cardiovascular disease, right? So what is the maximum cardiovascular risk you think is for? So one is for tobacco, one is for salt intake. They should be reduced by, there should be more than 30% reduction. Maximum reduction should be for these two risk factors. Next in line, so salt and tobacco, you are done with the current tobacco use 30%, and salt intake should be 30% reduction. That is for two important risk factors. Next is other risk factors, that is alcohol and physical inactivity. Alcohol and physical inactivity, there should be reduction of more than 10%. More than 10% reduction in physical activity and alcohol. Please remember, tobacco and salt intake are bigger risk factors, more reduction. Alcohol and physical inactivity is of course one of the important risk factors, 10% reduction. Then is special topic hypertension. It should have more than 25% reduction, because hypertension is the one risk factor which is most importantly modifiable risk factors. So these are the important 5 things you should note for Global Action Plan. And then is of course 50% people should be eligible for drug therapy, and 80% people should be having access to these medicines. These are also part of the non-communicable disease. So there is 10% reduction in harmful alcohol, yes. 10% in physical activity, yes. 30% in salt sodium, yes. 30% in raised blood pressure, no. This is 30% for tobacco or smoking. 30% reduction for smoking, this is correct answer. So which is the one which you are going to mark? Option number D is the best possible answer. Last question to close off this session today. Last question I'm going to take. Any doubts you have, you're most welcome to ask. Last question to close off the session today. As per the NPCB conducted, visual impairment is defined as visual acuity of how much? As per the NPCB survey conducted, visual impairment is defined as visual acuity of how much? Less than 3 by 18 in the better eye with available correction, less than 6 by 60 in worse eye with best possible correction, less than 6 by 18 in the better eye with best possible correction, or less than 6 by 18 in the better eye with available correction. What do you think is the best possible answer? This is a simple question and it has been discussed so many times in your exam. I would like how many students should be able to answer. You should be able to answer this. Less than 6 by 18, 3 by 18 or 6 by 60. Then you have to decide whether it is better eye or worse eye. And then you have to decide whether it is available correction or the best possible correction. So beta, many of you are answering option number C, which absolutely looks as the best possible answer, but जोर का झटका, धीरे का झटका जोर से लगता है, and that always happens. This is NPCB VI update for you. This actually update happened long time back. This file can be downloaded from my website also. It can be downloaded from my website, that is psmsimplified.com/updates. This is also one of the resources that you can use. You just go to this website psmsimplified.com and you go to /updates, and there'll be a lot of PDFs over there. You can of course download that. Right now I would not suggest you to go to that website because there'll be huge amount of material over there and you'll get confused. But if you are looking for something very discrete, you're looking for cardiovascular disease, you're looking for rabies guideline, you're looking for snake bite protocols, you go to the website and you will find all your important documents over there for downloading. So coming back to this update, when do we call visual impairment? Visual impairment is, can you see this? It is presenting visual acuity of less than 6 by 18 in the better eye with available correction. With the available correction, it is not with the best possible correction. That is what the whole game changer is. This is a direct screenshot I have taken from the NPCB VI guidelines. It is with available correction rather than taking as the best possible correction. So it is less than 6 by 18 in better eye with available correction rather than taking as the best possible correction. Yes, previous times we were taking as the best possible correction, but now we take as with the available correction. So when do we say visual impairment? Visual impairment is less than 6 by 18 in the better eye with available correction. When do we say functional low vision? Functional low vision is a person who has less than 6 by 18 visual acuity in better eye with available correction, but who can use or is able to use the vision for his planning of the task. So his vision is less, but he is comfortable with that vision. That is called as a functional low vision. You don't need to treat these people with the functional low vision whose vision is less than 6 by 10, but they are happy with their life. They are working as farmers, or they don't have any work to do, or they are retired and they are okay with their vision, or their age is very high. So that is called as functional low vision. When do we say blindness? Blindness is visual acuity less than 3 by 60 in better eye with available correction. Same answer, same criteria. Okay. So I hope everybody also knows what is the most common cause of blindness in all age group. It is cataract. Cataract is the most common cause of blindness. So age more than 50 years. What is the most common cause of blindness? It is cataract. Blindness is cataract. What is the most common cause of visual impairment? Visual impairment is also cataract, but age less than 50 years. Age less than 50 years, major cause of blindness. Can you see over here? It is corneal opacity. Age less than 50 years. It is not cataract. It is corneal opacities. Corneal opacities could be due to multiple reasons, but generally speaking, corneal opacities is the most common cause of visual impairment for age blindness and visual impairment for age less than 50 years. For visual impairment, age less than 50 years, it is refractive errors. Refractive errors. For blindness, it is corneal opacities. So please note that you should be knowing about these most common causes of blindness and most common cause of visual impairment for your exam. And so with that, I'd like to thank you very much for watching this whole module on communicable disease, non-communicable disease and the related national health programs. You should join in for Instagram if you want all the recent updates. If you have any MCQs or you want any doubts to be solved, there is a Telegram group. Search for my name Mukhmohit01 or Mukhmohit PSM. So you will find on the Telegram group, and just put your question over there. Individual replies I would not be able to answer because there are so many hundreds of questions you get over a few days time. So Telegram group is what I am active in. Any doubts you have, you're most welcome to ask over there. Recent updates, you have the Instagram, and of course the PSM Simplified. This is the website where you can download any type of document that you need, psmsimplified.com, and you can download any type of document that you need from public health point of view or national health programs. So I'll share with you the weekly topic schedule also for the next upcoming week. I will make it and maybe post it tonight or tomorrow morning. Okay. So PDF, yeah, it will be available, but क्या करोगे PDF का? वैसे ही online it will be available every time. Okay. Okay, it will be available on your YouTube channel. On my YouTube channel, this video will be available. Okay, all the very best and have a good night, and thank you so much, and keep on studying. सिर्फ ये videos attend करने से नहीं होगा. You have to solve the MCQs. So make sure that you are solving the MCQs every day from whatever topics I'm telling you. Okay. See you next week on Wednesday at around the same time. Thank you so much. Any doubts होंगे तो please ask me, and all the links are already there with you. Thank you. Good night.